Case example 2, we have a 60-year-old retired male. Chief complaint, left anterior hip and groin pain. He has had 3 prior hip replacements with revisions over the last 7 years. That in itself should really raise some flags or at least get your attention. Past medical history, he has congestive heart failure. He's on a low tensin medication, taking a baby aspirin and taking Zocor. The other thing that we need to mention with this case is this patient called the physician and requested PT for his hip. He's seen you in the past, he likes you, he trusts you, he wants to go back and see you. Now take a look at these vital signs. We really need to make sure that we're monitoring those vital signs because as we can already see, that blood pressure is very, very low. That is lower than normal blood pressure. His heart rate is a little higher than what we'd like to see. It's not outside the realm of norm, but 86 beats per minute at resting is a little higher than typically what we like to see. Pulse ox, also a little low, right? We all know that it requires 88% of pulse pressure or pulse ox to perfuse the tissue. So 89% is getting very, very close, obviously, to that 88%. So really and truly, we should have some flags here that we're looking at as physical therapists, even without knowing any of the other pertinent information and without even laying a hand on this patient. So we go a little farther with this case example, and we notice when we take a look at him, we have some scar tissue over the left hip, greater trochanter. That's perfectly normal after so many hip replacements. Now, this next one, that should really speak to you. Bilateral lower extremity pitting edema. This particular patient has some pitting edema. That is not a typical presentation after a hip replacement. We also have a positive Thomas test. And this patient in particular has a 30-degree hip flexor contracture. But neuro looks pretty good. So what I want you to do is, at this point, pause the slideshow presentation and really think about, what should I do? Should I treat this person? Should I send this person to the emergency room? Or should I do some other testing? Or should I continue to treat this person, but then have them go see the physician as well? So in this case, really what we want to do is we want to monitor those signs and symptoms. We want to definitely call the physician. And we want that patient to go in and see the physician as well. Because this person with the vital signs and the pitting edema probably has a cardiovascular issue. Remember, this stuff, the low blood pressure, the pitting edema, is not going to get better if you exercise the patient. So we definitely want to send this person back to the physician and make a referral. Case number 3, now we have a 68-year-old retired male from the military, and we have this insidious onset of right shoulder pain around 3 months. That alone should be enough to make you suspicious. His primary care physician sent him over to PT. They want him to see us for a little while. Diagnosis says shoulder impingement. X-rays read perfectly normal. You guys will learn very quickly that X-rays will only show you bone. They don't show you anything else. And they are a very small portion of the picture. Past medical history, we got a couple things going on here. We got hepatitis. We got some type 2 diabetes. He has some weight loss, but he's also seeing a GI specialist. So at this stage, what I want you to do is think about, what do we want to look at? What type of signs and symptoms would we expect? What type of special tests would we want to see? Obviously, we're going to do things like take vital signs. Obviously, we want to dig into that past medical history just a little more. But then the other thing is think about how this person fits into the SINS or the PQRST type of structure. We don't have any sort of mechanism of injury. Anytime you see someone that does not have a mechanism of injury, I really, really encourage you to be suspicious of that person in terms of their injury. So what we really want to do here is we really want to dig into that past medical history. Ask questions like, when does it hurt? Do activities make it better? Do activities make it worse? Just because somebody doesn't have a mechanism of injury doesn't mean they don't belong in your clinic, but we definitely need to ask follow-up and probing questions. So definitely make sure you're getting into that medical history. We do a subjective exam. Got some right shoulder pain going on, no trauma. Nothing makes it better, nothing makes it worse. That again should really get the antenna up, as I like to say. It's worse in the evening, and he can't sleep with it. But, we do a physical exam, and it looks like it probably is a frozen shoulder. He's showing some of those capsular patterns, and it looks like it might be a frozen shoulder type of case. We do some joint mobs on him day 1, and we get a little bit of mild improvement. So with this sort of case, we're getting a little bit of mild improvement. We're doing some joint mobilizations. We're doing some stuff with them. We're not necessarily going to make that referral right away based on what we see here, because he did improve with some treatment. As we're going to learn later on, if someone does not improve in treatment or is getting worse with treatment, that alone is going to be enough to warrant a referral. Obviously, we're not going to treat people for an extended period of time that are not improving with our treatment. So as we saw with the last slide, we got a little bit better after one treatment. Now we have a much different picture in front of us. We see him a week later. Holy cow, the pain's so much worse. It's intractable. It's keeping me up at night. This is awful. And, yeah, I've lost about 20 pounds, but I'm also seeing this GI doc who's helping me lose weight. We already know this patient's going to regular follow-ups with his primary care physician for his diabetes management, and he's already seeing a specialist for hepatitis. So at this point, again, what I want you to do is pause the slideshow presentation, think about this, and think about what you would do next. Would you continue to treat this patient? Would you send this patient on? What we're going to do with this patient, if the patient's having worsening pain, is intractable pain, he's waking up at night, send this patient back to the physician and say, I think we need to take a deeper look at this. Reason being is because, yes, he showed some mild improvement with symptoms from his symptoms with your care, but he also is having this intractable pain, and he's having that red flag of waking at night. It could be as simple as a rotator cuff tear, or it could be something like a Pancoast tumor or something a lot more serious. Either way, you want to make sure you're safe in your practice. You want to make sure that you're not liable for treating someone that should not be under your care. So, in my opinion, and research does validate this, you want to make that referral in order to keep yourself safe in your practice.